Thank you for joining me. This is Jennifer Gross. Very happy to be able to chat about the SNF QRP with you today. Okay, so let us get started. So first of all, just a disclaimer that this webinar is for educational and informational purposes only. It is a high-level summary. Goodness knows I won't have enough time to go into deep depth on all of the SNF quality measures that we have to deal with. But just know that this is for educational purposes only. How you interpret the regulations and how you apply the regulations to your processes, that is up to your organization and your compliance team and your facility and corporate leadership, because everybody has to apply the regulations in their own way, in their own practice. And of course, any information that comes from CMS, including about the SNF QRP program, is subject to change as new rules are being released. So today we are going to, in the next hour, go over SNF quality reporting program, SNF QRP. So when you leave this presentation, you should be able to summarize and give an overview of the framework and the various measures that are used in the SNF quality reporting program. You'll be able to discuss the updates to the program that are being applied for fiscal year 2022. You'll also be able to understand and explain the data reporting threshold that is very important to ensuring that your SNF QRP measures are able to be reported and potentially could ensure that you do get your full annual payment update every year from Medicare. And you'll be able to take away 2 strategies at least to apply in your own facility, in your own organization, to make sure that you're successful in the SNF quality reporting program. So first of all, what is the SNF QRP? Of course, we have so many different quality measurement, quality reporting programs, some of which are VBP or pay for performance, and some of them are not, and simple, straightforward quality reporting. Some of them are publicly available, some of them are not. We're going to focus specifically on the SNF quality reporting program. For those of you who can remember way back in 2014, the IMPACT Act, which was promulgated and passed by Congress, is a large act having to do with the integrity of the Medicare program for Medicare beneficiaries. The piece that we're looking at, of course, is relevant to Medicare Part A beneficiaries. And part of the IMPACT Act requires that cross-setting outcome reporting is made available for all Medicare Part A beneficiaries. Now, what cross-setting means is, if you think of a typical Medicare skilled length of service or episode of care, you begin in the hospital usually, and you move on potentially to a skilled nursing facility for a while, maybe on to a home health agency. You may do a stint in an inpatient rehab facility or a long-term care hospital for those who have long-term chronic, very serious conditions. All of those are considered different settings that Medicare Part A reimburses for. Now, each of these settings has their own data set, which mostly aligned with each other, not completely, which is why the SNFs got to learn and love all about Section GG several years ago. That's the reason why we have Section GG now, to be able to have equivalent reporting, equivalent language that can communicate between settings. So if the SNF and their MDS and home health agencies with their OASIS data set have similar metrics and standardized data sets that can be reported on, so that you can intelligently follow a person from the SNF to home health. So all of this reporting feeds into the SNF quality reporting program, or to the quality reporting program rather, because the SNFs have their QRP, home health, IRFs, LTACs, they all have their own quality reporting programs. But the idea is to be able to follow the person throughout their Medicare Part A skilled stay. So as you probably gathered from what I was saying on the previous slide, the population for these measures are Medicare Part A only. So what we are looking at in the SNF quality reporting program are those patients, short-term patients, who have completed a Medicare Part A skilled stay. So this is not Medicare managed care, it's not a Medicare Advantage plan, this is traditional original recipe Medicare Part A. And what is required in order to define the population for SNF QRP is a completed stay, which means the initial Medicare assessment, aka the 5-day MDS at the beginning, and at the end of the stay, the SNF PPS Part A discharge. Now that discharge may or may not be combined with an actual discharge from the facility. The important point is that the Medicare stay has ended. So you have that completed Part A stay. Now, not all Part A stays are included in this bucket. So of course, incomplete stays, if we say that the completed stay is required for SNF QRP, that means incomplete Part A stays are excluded. Now, the specific definition for an incomplete stay varies from measure to measure, so you can certainly dig into the measure specifications to get the real details. But in general, an unplanned discharge, as coded on the MDS, so somebody goes out to the hospital 11:45 at night unplanned, that particular stay would be considered incomplete. Now that person may come back within the 3-day window and continue on their stay, but that unplanned discharge is not considered a completed stay. A discharge to the hospital, same thing, those are usually unplanned anyway. A Part A stay that is less than 3 days, or if the resident or patient dies during the skilled nursing facility stay. So all of those are excluded from the SNF quality reporting program. So what we are looking at here is basically the ideal state, the typical short-term rehab stay in a SNF, where they come in, they have their 5-day initial Medicare assessment, and they continue through their post-acute stay until they are discharged from Medicare coverage. So how is SNF QRP reported? Well, there are a few different ways. You have your internal reporting through your CASPR reports. There is a folder among all the many, many folders in CASPR for SNF quality reporting program. So it's separate from the old traditional QMs that you're used to pulling from CASPR. And in that folder, you'll see facility level and resident level reporting, your provider threshold report, which is very important to make sure your data is complete, and your review and correct reports, which we'll be talking about a little bit later. Now, the SNF QRP measures are also publicly reported, and it's kind of confusing. And when Nursing Home Compare got their facelift and was incorporated into the overall Care Compare website, personally, I think it became even more confusing. But here's how you can find those SNF QRP measures. If you go look up a facility in Care Compare, and I just have a couple of screenshots here. So if you click on the button that says View Quality Measures for that particular SNF, these guys are a 5-star, of course. And then you scroll down in that little window that pops up with all the quality measures, you'll see a section called Additional Quality Measures, Short Stay Residents. These are the SNF Quality Reporting Program measures. So it doesn't have a big flashing sign that says SNF QRP on it. You have to kind of look and know what to look for. So scroll down a little bit below the traditional short stay QMs, you'll see the additional quality measures. That's where you'll find them. So these are publicly reported. So anybody could look them up on Care Compare. Now, it's important to keep in mind because we've gotten very used to the concept of value-based payment, pay for performance. If you do better than your peers or if you improve over time, then you'll get more money or get more of your money back, technically. But SNF QRP is not a VBP program. It's not pay for performance, it's pay for reporting. However, SNF QRP can affect your organization financially because there is a 2% annual payment update or APU reduction in your Medicare rates for skilled nursing facilities who don't successfully participate in the program, and you can hear my air quotes there. So successful participation is when 100% of all of the data items that are included in the SNF QRP have been reported on at least 80% of all of the MDS assessments that are applicable for the quality measure quality reporting program. So your Medicare 5-day initial Medicare assessments and your Medicare end of stay assessments. So the long and short of it is no dashes in any of those items. So the idea is that you need to report all of your data, and if you don't report all of your data on the MDS, then CMS cannot accurately measure your performance and report on it. So they've over the years, CMS has been a lot more strong in their messaging, saying, hey, we know you can put a dash in an MDS item. That doesn't mean you should. And now there's an actual potential financial implication to doing so too much. Now, as you know, with the COVID-19 pandemic, there has been CMS has hit the pause button on a lot of their public reporting and measure reporting, and that includes SNF QRP. So the reporting of SNF QRP publicly is not going to completely resume until next April, but the data submission requirements are still there. So don't not that you would, but don't develop any bad habits of dashing MDS items when it's really a better option to complete those items. You will it will behoove you in the long run to make sure that those items are being completed. And I'll talk a little bit later in the presentation about dashes and the MDS and when you can and shouldn't use those items, those options rather. So let's take a look at the MDS-based SNF quality reporting program measures and their data elements. And again, this is a very high-level overview. We're not going to go into the specific details of every single measure, but in general, these are the sections of the MDS that are included in these MDS-based measures. And in the handout and at the end of the presentation, I have links to all the CMS resources so you can download the measure specifications if you need to get into really granular detail. So first of all, the biggie that was the biggest hurdle for SNFs to get used to is the functional status, because the way that SNFs have traditionally reported on a patient's or residents' physical functional status in Section G is very different from the way just about every other setting reports on functional status. So that's why we have Section GG right next to Section G to be incorporated in the SNF quality reporting program and to be used in PDPM. So what we're looking for here, there's actually 5 different measures. So there is the actual percent of patients with an admission and discharge functional assessment and a care plan that addresses function. Now that really catchy name simply means that your facility was compliant with reporting all the data elements that are needed for calculating those measures. So this top measure was the first one that was implemented in SNF QRP because CMS rightly said that, hey, these SNFs have to start actually reporting these data elements to CMS so that we can start calculating performance. So that first measure is simply a reporting process measure. Then we get into the actual outcome measures. So the change in self-care and mobility scores. So this is the change in the overall scores in the self-care section and the mobility section, so GG 130, GG 170, between the initial Medicare assessment and the PPS discharge assessment. And then there are separate measures for the discharge self-care and mobility score. So that's just off of the discharge PPS assessment. So what this includes is in Section GG, you know there are multiple columns. There's the admission performance column, the discharge goal column, that's column 2. And then discharge performance column, column 3. Now there's an interim performance column in there depending on what item set you're looking at. That is just for the interim payment assessment. It's only for payment, it's only for PDPM, and it's not included in the SNF QRP. So don't worry about interim performance. What we are looking at is admission, the goals, and the discharge. So what we're looking at in section GG is the actual performance, admission and discharge, as I said, for both self-care and mobility. So this goes right from the beginning of section GG 0130 through basically the end of GG 0170. There are a few other mobility items in there that are not included. But basically the idea is every single one of those items has to have an allowable code in it. For the actual performance. So no dashes at all in self-care admission, discharge, and mobility admission and discharge. There has to be at least some kind of code. Now for the discharge goals for self-care and mobility, there has to be at least one goal coded with an allowable code. You can dash everything else as long as you have one code saying this is a discharge goal for this, for walking 150 feet. That's all you need in order to be compliant with reporting for the discharge goals. You can have more than one goal. You can have as many goals as you want, but there has to be at least one. Okay. And as I said, we'll talk about dashes in a little bit because dashes really play a big role here. Now moving on to skin, changes in skin integrity, post-acute care pressure ulcer injury. In other words, this is yet another short stay pressure ulcer measure that is not quite the same as the pressure ulcer measure that is a short stay quality measure. It's very similar though. So what we are looking at here is the data elements. Now, of course, the actual number of pressure ulcers or injuries, that's all from section M of the MDS, M0300, B1 through G1, so stage through all the way through the unstageable, so unstageables are included. And then the number of those pressure ulcers and injuries that were present on admission, entry or re-entry, because we're looking to capture those changes between the time of admission and the time of the assessment. So if a pressure ulcer or a pressure injury appears on the assessment that was not present on admission, that patient did not come in from the hospital with that ulcer at the same stage, then they will trigger for the change in skin integrity. Now, there are some risk adjustment elements that are included in this measure, and this really tends to trip people up. Bowel continence, height and weight, and 2 diagnoses, one for PVD, PAD, and diabetes. So the diagnoses, it doesn't really matter so much because they're checklist items, so you don't really have to worry about dashes. But what tends to trip people up the most with this measure is dashing the height and or the weight. Most of the time when I'm looking at a client's reporting for their dashes and they're wondering why are we triggering that there's a dash that impacts this pressure ulcer measure, it's the height or the weight, or both, that are being dashed. And that is simply because these are risk adjustment items that are very relevant to this measure, and CMS wants 100% of all data elements to be reported. So that's why you could potentially get financially dinged for dashing, for example, weights, if it happens too frequently. Remember, your threshold is 80%. And sometimes dashing that weight is unavoidable, but you don't want to fall into the habit of doing that as your default. Okay, so I apologize. There we go. I skipped ahead. So there's a couple of other MDS measures that we want to talk about. Again, here is another measure that is an adaptation of an existing measure. Falls with major injury forever. We have had falls with major injury as a long stay quality measure. SNF QRP has taken sort of the long stay measure and applied it to the SNF QRP population. So this is falls with major injury for that Medicare Part A population for the number of falls in submission entry or prior assessment. So if a fall with a major injury such as a fracture, an open laceration, a closed head injury with loss of consciousness, that sort of thing, that would trigger for this measure in the SNF quality reporting program, even if it would not trigger for that same person in the falls with injury long stay QM. So that is another one that kind of takes some getting used to. Now, something that was entirely new as of a couple of years ago is the drug regimen review section. So there are a few different pieces to this. Drug regimen review at the time of admission on that initial Medicare assessment. If any potential medication-related issues are identified on that DRR, was there a follow-up within 24 hours to the attending physician or physician extender, and were interventions put into place as ordered by the physician every time there was a potential medication related issue that was identified throughout that resident's stay. So the DRR and the medication follow-up measures are captured on that initial Medicare assessment. The medication intervention section in 2005, that looks at the entire stay at the end of the Medicare stay. And was there intervention, was there follow-up every single time that a potential medication issue was identified? You want to make sure that that gets captured. And of course that, as I talk about it a little bit later in the processes, that makes the documentation and the communication of meeting with the physician, relaying pharmacy recommendations, et cetera, really, really important to get that documented so you can capture it. Okay, so SNF quality reporting program, of course, also has claims-based measures, and these are QMs that you're not directly reporting them from the SNF. They're not off the MDS. They are calculated for Medicare Part A claims, most of which are from the hospital, actually. And the focus in these measures is on the overall utilization of Medicare itself and transitions of care between settings. That's why it has to be claims-based, because the MDS is only looking at what occurs within the walls of the skilled nursing facility and while that person is a resident in that skilled nursing facility. Claims take the broader view and can identify things such as potentially preventable 30-day post-discharge readmissions and successful discharge to the community, where somebody is discharged from the SNF and they are able to successfully stay out in the community beyond that 30-day threshold and out to the full 100 days. Medicare spending per beneficiary, of course, in order to get that average number of spend, the Medicare claims are required on that. So these are measures that you don't directly report. Some of the QMs, such as the readmission measure, do use some MDS data elements for risk adjustment. But the real key here is the management and the relationships with your hospital referring partners, as well as your post-discharge community resources such as home health, to ensure that transition of care from the hospital to the SNF to home care and beyond are successful, and that person does not have to return to the hospital. Okay, so that's a lot to go through, and I've got more to come. So there are some new measures and some updates that have been put into place or are about to be put into place for fiscal year 2022, which of course begins on October 1st. And the focus with these new measures, not surprising, is on infections and infection control and vaccination, specifically COVID-19 vaccination of staff. So first, we're going to talk about the SNF healthcare-associated infections requiring hospitalization, or the SNF HAI. I have to learn how to say that. So this is a risk-adjusted measure And it's the rate of these healthcare-associated infections, or HAIs, that were acquired during the SNF stay that resulted in that resident or short-term patient being hospitalized. Now, this is, again, a claims-based measure because the hospital claim is required in order to capture that infection diagnosis. So if a resident comes to your facility and they are in their post-acute stay and they develop urosepsis and they end up having to be admitted to the hospital, it's that hospital claim that is going to have that diagnosis of sepsis. So this list that I have on the screen here is by no means an all-inclusive list. There is a technical report that has the full list of all of the ICD-10 codes that are involved here. But we're looking at the general infections that we are most used to seeing, such as sepsis, respiratory infections, GI, genitourinary infections. There are some neurological infections, such as encephalitis, device-related, so an infected prosthesis from a hip replacement, for example, eye and ear infections, skin infections that require hospitalization, and also infections of unknown site or an unknown organism. So you could even get that broad. But if that infection is the reason why that patient or resident had to be discharged from the SNF and admitted to the hospital, that's what is being captured here. Now, the actual public reporting on Care Compare begins next April. So you will be seeing some provider preview reports in January of 2022, right after the new year. And the initial reporting period that we are looking at, and I'm going to say this very slowly, the initial reporting period that we are looking at is fiscal year 2019. So that is October 1st of 2018 to September 30th of 2019. So it's in the rear view mirror. It is a long ways ago. It's even pre-COVID, if you can remember those times. So just know that, that this information that is about to be reported in April 22 is already in the books. Now, working on processes going forward is all we can really do, but just be aware that that initial reporting period has long passed. Now, the other piece, which is looking at an entirely new data set that we are grappling with here, is the COVID-19 vaccination coverage among healthcare personnel, or HCPs. So, as you know, SNFs are now required to report their vaccination status, both for staff and for residents, to the CDC. And this is a specific rate that CMS is now reporting on because of concerns of low rates of vaccination in skilled nursing facility personnel. So what is being reported on is, this is a cumulative number of HCPs who work in the SNF during the reporting period who have received the full course of COVID-19, whether that is 2 doses of Pfizer or Moderna, or 1 dose of Johnson & Johnson, or whatever other vaccines we end up with in the future. Whoever has been fully vaccinated will be counted in this list. So, of course, higher is better, just like the influenza and pneumococcal resident vaccination measures. So who are considered HCPs? So facility employees. Now, it doesn't matter if this person is the front desk, in the laundry, or a nurse on the floor, or a CNA, or a therapist. These are all facility employees. Licensed practitioners who work in your facility, so your physicians, your nurse practitioners, your PAs. Any adult students or trainees or volunteers, your volunteers are counted, and other contract personnel, and that is optional. So anybody who is excluded, now the only exclusion is a medical contraindication to the COVID-19 vaccine. And the FDA, the CDC, and ACIP have released and published specifications of what is considered to be a medical contraindication as far as they are concerned. So there's a very narrow exclusion here. Now, this reporting is uploaded to the National Health Safety Network, or the NHSN. So you folks in the facilities, you are familiar with that reporting portal by now, since the reporting of vaccination has been mandatory for several months. Now, the requirement is that facilities report their data weekly, weekly data rather, at least once per month. And if you report your vaccination 3 times this month, the most recent week's data from that month will be used for the calculation, and that will be added to the cumulative rate of your vaccinations for your staff. Now, the reporting time frame is going to build up. This is going to be a quarterly rate. And we're going to be beginning with Q4 of 2021, so beginning October 1st through the end of the year. And this will be applied to the fiscal year 2023 SNF QRP. So not this coming year that it's about to start, but the following fiscal year. Once we get that first quarterly rate passed, then the vaccination measure will follow the standard 4-quarter format in subsequent fiscal years. So we'll be looking at what we're used to, which is a 4-quarter rate for the quality measures. So these next couple of slides are actually kind of recycled from my previous webinar on the proposed rule for fiscal 2022, because I just wanted to remind everybody that we are still in a data freeze for the SNF QRP. And what is currently being reported on is data from calendar year 2019. So these numbers, both for MDS, and I'll talk about the claims measures on the next slide, are going to continue to be held constant in Care Compare and in the SNF QRP reporting until January of 2022. Now, with the first refresh, you're going to see data from Q3 of 2020 through Q1 of 2021. So that's 3 quarters worth of data. Now, remember, Q1 and Q2 of 2020 are not going to be reported on because of the pandemic. So reporting will pick up again in Q3 2020 data. So we'll start off with 3 quarters worth of data, and then with the April refresh of next year, then the normal reporting of 4 quarters will resume. So as I said earlier, we're not going to be fully back on track, please God, until April 2022, as far as the reporting is concerned. So this table is from the proposed rule and from the final rule that breaks down the data refreshes and what quarters are going to be reported on as of each refresh. And that's my reminder. Q1 and Q2 2020 data will not be reported. Same goes with the claims data. The first 2 quarters of 2020 data will not be reported on. The claims data time period has always been kind of different from the SNF data because of the time window and it's usually earlier data, 2 years worth of claims data that are being reported on. So what is currently being reported is Q4 of 2017 through Q3 of 2019. So that's going to hold until January. And then we are going to be looking at 6 quarters of data from Q4 of 2018 through Q4 of 2019, and then skipping over Q1 and Q2 and including Q3 of 2020. So there's going to be kind of a blank there, but we're going to just skip over that piece. Then the October refresh, it's going to move everything forward a quarter. And then October 2023 is when we will finally resume the normal reporting for the claims-based measures of 8 quarters worth of data uninterrupted. So it's going to take a while because the claims data takes a while to move, but eventually we will get back on track. Now, this is all contingent on the public health emergency finally being resolved, of course. Now, In addition to the COVID-19 public health emergency, there has always been disaster exception and extensions for various emergencies. Most usually those are natural disasters. So I just wanted to put this up here because CMS did issue reporting exceptions for those facilities that were impacted by Hurricane Ida. On September 16th, they released these reporting exceptions. So this only applies to SNFs that were actually affected by the storm, and the SNFs have to be located in Louisiana, Mississippi, New Jersey, or New York. So if you were affected in such a way that you have difficulty keeping up with the data reporting requirements, you can request an extension or an exception from the reporting requirements as you get back on your feet and stabilized after the disaster event. So this is kind of the standard language for these natural disaster exceptions. Just know that there's been a new one that's been released recently because of the hurricane. Okay, so let's talk about the data submission threshold. Here's where we roll up our sleeves and get into the weeds of the MDS. Remember that what's at stake here is 2% of your annual payment update. So that could be a pretty significant chunk of your Medicare reimbursement, particularly for facilities who rely very heavily on their Medicare Part A reimbursement, traditional Medicare. So what we are looking at here is the submission requirements for skilled nursing facilities. So what we are looking at here is not just the MDS data submission threshold, which we have had since the beginning of SNF QRP, but now we also have the National Health Safety Network data submission requirement for the vaccination measure, for the HAI, healthcare professional vaccination requirement. So you have to meet both of those requirements in order to avoid the 2% APU penalty. I'm going to say that a little differently. If you fail to meet just one of those requirements, so if you are below your 80% threshold for the MDS submission requirement, but you make your vaccination reporting requirement to the NHSN, you are still subject to the 2% APU penalty, and vice versa. So the real key here is to understand what the data submission requirements are and what the processes are that you have going on in your facility and your organization to keep those wheels turning to avoid that 2% penalty, because that's the last thing you want is to lose 2% off your APU because you're missing data. So let's talk about the MDS submission threshold. So as I said earlier, this threshold is the percentage of all the assessments that are used in the SNF QRP that have 100% of all the required data elements. So out of all of those MDS-based measures, every single one of the MDS items that are involved in those measures, and that includes risk adjustment measures, covariates, some of those measures have a lot of moving parts, like we saw with the pressure ulcer measure. All of those data elements have to be filled in with an appropriate code, not a dash. So the denominator is the number of those MDSs submitted to CMS, and the numerator is the number of those assessments that have 100% of their data. So if you have 95 out of 100 MDSs that have 100% of your data, your submission threshold, your submission percentage is 95%. So as a reminder, the assessments that we're looking at here are the Medicare PPS 5-day or initial Medicare assessment and the Part A PPS discharge assessment, which may or may not be combined with an actual discharge from the SNF. But the important thing here is that it is coded as a Part A PPS discharge to mark the end of the Part A stay. So again, if you're reporting less than 80% of the required data elements, then you are subject to that APU reduction. So let's talk dashes. Again, for those of you who know me, I'm a recovering MDS coordinator. So I'm going to talk MDSEs for a little bit. A dash on the MDS means no information, and this is actually directly from the manual. A dash indicates no information. CMS expects dash use to be a rare occurrence. Reading between the lines of CMS, that means don't do it if you can possibly avoid it, because the expectation is that each of those MDS items has an option to code, and it might be none of the above. You can use that code, just don't use a dash if you can possibly avoid it. So if you look, for example, at section GG, which has so many items and so many variables that are included in those functional score measures for QRP, there are codes for the resident refused or not applicable because it was an activity that the resident or patient did not do prior to the current illness, or not attempted because of medical condition or safety concerns or environmental limitations. So there are codes for every single one of those scenarios, which means that there is really no reason to dash at all if that resident was present in your facility during the assessment period for section GG, and somebody was able to do that assessment. You should be able to put a code in that item. Now, if there is truly no information available, for example, the classic example that we see this the most is with the weight for a resident who may be completely on palliative care. You don't have a bed scale. You're certainly not going to move that person in order to weigh them if at all possible. Then there's no weight present and there was no information available for that person's weight at the time of admission. Now, that does happen, but it shouldn't be common because you want to watch that 80% threshold. Because again, it only takes one item to be dashed on an MDS in order for it to count against you. So think of it this way: go as far upstream as possible to prevent those dashes from occurring on your MDSs. Now, your MDS coordinator knows the assessment backwards and forwards, and she or he is also most likely very familiar with what MDS items are used in each quality measure. They probably know it in their sleep. So it would probably behoove the rest of your team, at least the facility leadership, to become familiar with which MDS items are considered in the APU calculation. And this slide here, again, we will make sure the handouts are available to you. This slide has a link directly to this document that I have a screenshot on the page. And it goes through every single MDS item that is used in each of the quality measures. So you know what needs to be coded on the MDS and what you should avoid dashing as much as possible. So the MDS coordinator, of course, but anybody else on the assessment team that contributes to the assessment through their documentation and through their interdisciplinary communication should at least be aware that, hey, you know, I need to be able to report on how this resident is doing in their upper body dressing for their discharge performance, for example. So the first thing you want to do is educate and raise awareness. Secondly, some kind of auditing tool to just catch whenever a dash is placed in one of those MDS items as you're completing the MDS. PointRight, of course, has our data integrity audit. Most electronic health record software systems have some kind of scrubber that will provide you with alerting under circumstances like that. It depends on the software, so check with your vendor if you're not sure. And there are other ways, including manual auditing if you have time. But auditing as far upstream as possible as the MDS is being completed will save you time on the long run, because further downstream, after you've submitted to CMS, then you're going to have to do some correcting. So when you submit an MDS to CMS, the final validation report comes in when that assessment or that batch of assessments is accepted into the KEYS database. So that final validation report, if you actually read them, and I know when I was directly working in the facility and submitting MDSs, I would scan through the final validation report, look for anything that was rejected, and if nothing was rejected, I said, cool, printed it out, filed it, moved on to the next thing. But I think you should look for the warning messages. There are specific warning messages that are error codes, and I have them a little further down the slide here. For example, error code -3891 is for a specific set of MDS items, I believe in section GG, that are in SNF QRP. That error code will tell you that, hey, there's a dash here, you should probably fix it. So once you receive that final validation report, that means the MDS is in the CMS database. So you'll need to investigate, potentially correct the MDS if you have the information. Of course, don't code the MDS if you don't have that information. But if you do have the information, correct the MDS and submit a modification. Now, there are also even further downstream CASPER facility level reports that give you the facility level view. So you have your SNF provider threshold report. There is a section for percent of MDS 3.0 assessments that were submitted complete. Of course, you want that to be 80% or above. And the MDS assessments with error number report. So that gives you a list of the MDSs that triggered one of those error codes that are related to dashing the QRP MDS item. So those error codes are on the slide here for you. And then last but not least, there is that SNF review and correct report, which you in general can review quarterly prior to the data submission deadline, and just make sure that you haven't missed anything either in your proactive auditing or your final validation report or your CASPER facility reports. This is kind of the horse has been out of the barn for quite a while, but just double check and make sure that you didn't miss anything before the end of the quarter and the data submission deadline. And speaking of those data submission deadlines, here is the most recent. Now these dates have been pretty consistent, but for Q1, the next data submission deadline as of today is September 22nd, the next data submission deadline will be November 15th, and that will be reporting for Q2. So that's quite a long time span, and the longer the time is from the assessment reference date of that particular MDS until you go to make a correction, the harder it is, because you have to go and look, you have to pull up potentially some closed records. Of course, you don't have it in your memory anymore if you did the assessment yourself. So you have a lot of time to make these corrections, but the earlier you do it, the easier it'll be for you. Okay, just checking my time here. Got about 10 minutes left. So let's move on to the NHSN vaccination submission requirements. Now, this healthcare personnel vaccination reporting requirement has already been in place, and it is mandatory for facilities to do this reporting weekly under the requirements of participation. And that noncompliance actually comes with a stick, which is the civil money penalties that are subject to if your facility or your organization is not compliant with the vaccination reporting. It's also subject to survey citations as well. Now, for the SNF QRP, as I mentioned earlier, you have to submit at least 1 week per month each quarter. So the bar is a lot lower for SNF QRP. If you meet that relatively low bar, you will potentially not be penalized, that 2% APU reduction. But remember that you really want to meet the higher bar of being compliant with the weekly reporting so that you are not at risk for survey citations and CMPs. So, always shoot for the higher bar if at all possible. Now, the NHSN reporting threshold is actually 100%. It's not like the MDS reporting threshold where it's 80% of those MDSs have all their data elements. This is 100%. There's really no wiggle room here. So when you report for a week, all of the required data elements, so all of those healthcare personnel job items need to be filled in at least 1 week per month in each quarter in order to meet that threshold. And when you are submitting every week, you really can't go back and make a change if you realize you missed something. So make sure that you're submitting weekly or at least every other week to make sure that you capture a full week's of reporting every month to meet that relatively low bar for SNF quality reporting program. Ideally, you are able to submit every week and have complete data. That will provide you with more of a cushion. Just make sure that you get in at least 1 week per month that has 100% data reported. So this really needs to be a priority process. I know you guys are busy. Everybody's got something to do. It could very well be the DON or the ADON or the QI manager or the infection control nurse who is responsible for doing this reporting primarily, but you do want to have at least one backup person that has access to the NHSN portal and knows how to submit the data so that they can cover for you if necessary. And between that and striving to submit weekly, you should be able to meet that data submission threshold. Now, you do want to make sure that your vaccination data is compiled and put together prior to submission. Just double check it, make sure there are no errors, because when you go ahead and upload, that's that. It helps if you submit the same day or time every week, like every type of habit, getting up in the morning, doing your workout or not doing or skipping your workout as the case may be, brushing your teeth at night, taking your medications. If you make it a scheduled day or time every week, then you're more likely to meet that obligation. And then, of course, when you make those submissions, go into the NHSN portal, look at your calendar, and make sure that each of those submissions are accepted and in the green and meet the data requirements. Okay, so we have just a few minutes left. Hopefully we'll have time for questions as well. So let's talk about the processes that drive your SNF QRP reporting, because it is all about interdisciplinary communication and documentation that feeds into your reporting. So first of all, let's talk about the infections, because this is, like the vaccination measure, this is a kind of a new realm for the quality reporting. But it all comes down to infection prevention and control, which is under the requirements of participation anyway. So ideally, you're meeting those requirements to make sure that you're in line with the overall regulation for participating in Medicare. So take a look at your infection prevention and control policies. If you have any prior survey deficiencies that were cited either from the infection control focused surveys or for your internal reviews, I know a lot of facilities had a lot of surveys over the last year, so just go back, make sure that you're not missing any of your prior deficiencies, and not just to prevent getting another survey deficiency in the future, but to prevent those infections from causing hospitalizations that may impact your QRP. Your infection preventionist in your organization, of course, is the go-to person for best practices, training, testing, return demonstration on donning and doffing PPE. And those are, again, are not just to make sure that you're checking off a list on an audit form, but preventing infections from spreading in a facility. Now, your medical director is there to be a resource from the medical standpoint and from the physician staff standpoint to draw the boundaries and develop protocols for when an infection, if it is contracted in the facility, what are the protocols for your capabilities for treating in place, IV medications, nebulizer therapy, portable x-rays, things like that, so that you have a solid foundation to be able to address these infections and treat in place if possible to prevent hospitalization. Or we've worked with facilities and hospital networks that have really come to a great understanding of understanding what the facilities are capable of. Even if a person is sent out to the emergency department for evaluation, the hospital knows that under these circumstances, they could potentially stabilize them, start them on their antibiotics, and send them back to the SNF without admitting them. So these are the sort of things that your medical director and your referral partners can be very helpful with in ensuring that you're managing those healthcare acquired infections as much as possible and keeping that rate of associated hospitalizations low. Now, there are going to be unavoidable hospitalizations, and that's when you get into your root cause analysis. So the remainder of the data collection, the MDS, it kind of seems standard now, but knowing how those key MDS items that feed into the quality measures are completed, what are the supporting documentation and communication and processes that drive that documentation, the MDS is not going to get coded unless there's something to back it up. The vaccination reporting, I already talked about the processes behind that. And any other key data processes, such as the infections, the ensuring that that hospital readmissions are being appropriately tracked in your EHR system so that it's accurate. How are your staff cross-trained to cover if necessary? Because things always seem to happen on weekends and holidays and on off shifts, as you know. And of course, auditing for accuracy is really key. We're all about that here at PointRight, but making sure that you know that these pieces that are driving your documentation and your MDS coding and your quality measure data elements are accurate and supported in the documentation. So whatever your processes are for auditing those pieces and incorporating that into your QAPI program, if necessary, it will help you in the long run as well. The final pieces are the people that drive the processes that drive your outcomes. So coordination within your interdisciplinary team, communication of changes between shifts, and making sure direct care staff are aware of something such as an infection control protocol that's put in place for a resident. Communication outside the facility with your hospital transfer partners, your home care partners as well, making sure that you are able to know who to call, who to communicate with if necessary. And helping both the residents and their families and their loved ones understand what's going on specifically with that resident, the diagnoses, the prognoses, what you're capable of treating in place, rather than having to unfortunately send somebody out because a family member insists on it. And of course, know how you can correct your data once it is submitted to CMS. Each of these data processes have their own different ways of submitting and correcting data. So just make sure that you're familiar with the options that you have available to you. And I already mentioned the QAPI program, so I'm going to wrap things up because we are just about out of time here. But if you identify a trend or a particular area in the quality reporting program that is of concern, then make that a focus of your QAPI committee. Make sure that the appropriate people are on that committee, such as your leadership, your medical director, direct care staff, hospital liaison, if necessary, to focus on that and the specific problem area and improve. Because it all comes down to compliance. So things like QAPI, infection prevention and control, MDS data submission, documentation, those are all tie into the requirements of participation. So if you are compliant and you meet those requirements to the best of your ability, and you're consistent with meeting those requirements, that leads to better outcomes and being able to identify when you're straying off the path what you need to do to address to get back on the path. And that will ensure that your compliance program is making sure that your residents are safe, your staff are safe, and that the Medicare Part A skilled benefit is being appropriately utilized. Okay. So again, we will make sure that the handouts are available to you in our follow-up email. I did put a message in the chat with a link to download the handouts as well. So while we're still going, if you can find that link at the top of the chat, go ahead and download. You will see those handouts. Thank you very much for your time today, and I hope you have a good afternoon. Take care.